Yep. Yeah. It's told me recording's in progress, so we can
All
go.
right.
You are most welcome to this video, and I'm delighted to welcome Dr. Jessica Rose. Jessica, thank you for coming on.
Oh, so welcome. It's my honor and pleasure to talk to you just one-on-one
Now,
for once.
just the two of us. Now, you're an independent analyst and researcher, and you've been preparing some data that the Romanian Parliament, I believe, you're going to be presenting that to shortly, and you've kindly agreed to give us a bit of a preview. So, but what's the first slide we're looking at, Jessica?
Well, just to give some people who may not know who I am an introduction, I'm
Mm.
looking at the vaccine adverse event reporting system data, which is it's a pharmacovigilance data set from the United States, in particular context, which is the COVID shots. So this isn't just the modified mRNA shots. This is all of the shots that they've rolled out in the United States. And so I've made a lot of presentations, I've created a lot of slides, and this is one of them that's probably one of the most telling. So a lot of people don't realize that even in January 2021, very, very shortly after the first day of the rollout of the shots into the United States, we had really strong safety signals. So that's what pharmacovigilance databases are for. They emit signals and they need to be analyzed in order for us to ascertain whether or not these signals are relevant to a particular product, whether they represent a danger to the public, whether or not we should make the decision to pull the products. And so this particular slide shows on the right the number of deaths. Now, this is absolute number. So there were 691 deaths filed to VAERS as of January 2021, January 31st. And that number far exceeds any pre-used limit of the number of people or that were allowed to die, quote unquote, in the context of a pharmaceutical or a biological product. So the question became, what's the cutoff? What's the threshold for the number of people who are, quote unquote, allowed to die or get
Mm.
injured in a specific way in the context of these products? Because A, this question wasn't being addressed, and B, we still don't have an answer, and we're up to tens of thousands of deaths now in VAERS, because the normal response would have been, whoa, we have to pull this product and do more experimental work. And because that didn't happen, we're looking at numbers like a death count that is completely like never been seen in the history of a product before on the market, that's deemed safe. So this is also not incorporating what we call the underreporting factor. So with any pharmacovigilance database that's passive, which means it's voluntary, you're going to have a certain percentage of underreporting. So only, like, say you have 100 people who suffered an adverse event of some kind, there's only going to be a certain percentage of those people that bother to file. And having said that, VAERS is notoriously annoying to file a report into. And even if you do file a report, there's no guarantee it's going to show up on the front end data set. So the estimates range from 100 times underreported to, I mean, we don't exactly know what the underreporting factor for these products are, but a very conservative estimate that I calculated was 31. So I think it's probably less than that for death, because my presumption would be that death would be far more reported than, say, something that wasn't as serious. But for now, we don't know the exact number. But again, having said that, because the numbers in VAERS in the context of these particular products are so high, and they're high relative to all the adverse events for all vaccines combined for the past 30 years, we don't even need to count the underreporting factor. There's like 1.6 million reports in VAERS right now in the context of these products. And in 2021, there was just shy of 1 million. And this is in comparison to the average number of adverse event reports for all products, all vaccines combined for the previous 30 years, which was about 39,000. So this is not comparable.
Jessica, this data on the right here, it's the people that had died by January the 31st, 2021. So that's what, 6 weeks or so into the vaccination campaign.
Yeah, pretty
now,
much. Exactly.
Is this data you've analysed retrospectively? So you've got this graphic has been, you've taken this from data that's directly on the vaccine adverse events reporting system from the States.
Yes.
Was this data available at the time, or is this something that's only been available in subsequent years?
That's an amazing question. And it's yes and no. Data was available at the time, but it's not the same as what it is right now. So every single week, VAERS data is updated and the numbers change. And I'm going to add a little point onto that, whereby we know that reports are removed without an explanation. So when I say the numbers change, they go up because the number of reports that are added to the database increase, but there are also some being pulled out, and we don't know how or why this is done. There's also this thing about a backlog. So I did a little bit of looking into this, and I looked at the difference between what you would see if you downloaded the the end of January data that came out of VAERS versus what you would see now if you had a master file that was the compilation of all the data from the beginning and you pulled out all the reports from January 2021. It's very different. So it shows the same profile. It shows a safety signal for, if we want to talk about death specifically, it absolutely showed that in January 2021 data. It did. But the signal is much stronger with all of the retroactively added data included. So this is a really good point, because some of the people might have said, well, you know, look at what we have in January 2021. The safety signal isn't that high. It's what we would consider acceptable. But the actual number of reports that had been filed by that point was much likely like way higher, because all of those reports hadn't been entered as part of a backlog that was accumulating. And by my calculations, this was a long time ago, it was about a 3-month backlog. So some reports are that were filed way back when in January 2021 are just being entered now. So it's a bit of a mess. So with everything VAERS, you have to take it with a grain of salt, and you have to present like the bare bones kind of facts, and you have to ask questions like the one you just asked, because it's very relevant. And I mean, it influences your perception of what's actually going on in VAERS. But having said that, the signal has been clear from the start, like even with the backlog, even with the underreporting, etc. So yeah.
So given that 3 months delay, so what we can safely say is by the end of April 2021, the safety signal should have been obvious if we were having real-time surveillance of pharmacovigilance data.
That's right. That's right. So that's exactly the point. By my perception, because I'm new to all of this, I never ever challenged, you know, the safety of a vaccine product before, which is funny because now I'm being called an anti-vaxxer. But yeah, it seems to very apparent to me from all of the conversations I've had with experts on these subject matters that the way things have been handled, you know this as well as I do, with anything involving COVID is very different from the way that it was handled before. So the rotavirus vaccine I think this was 1999. There was a handful, just a handful. I think it was, I'm pulling this out of the air based on something I'm remembering. I think it was about 30 reports. It might be a little less, might be a little more, in children in VAERS of intussusception. So you know what that is. It's painful. It's folding over of the bowel, and it's in children.
Yeah, so telescoping of the bowel.
Brilliant. So
very, very, very dangerous condition.
Exactly. So this comprised a safety signal, which is listen, VAERS works really well. That's another point I'm making in these slides that I'm presenting to the Parliament. It's a functioning pharmacovigilance database. It has functioned in the past if it's being monitored and if the safety signals are being assessed properly using causality assessments and all of these things they've always used. So they did a causality assessment, which is using Bradford Hill criteria, and they assessed that the rotavirus vaccine that was rolled out was very likely. They have all these degrees of likelihood that the thing is causing the other thing. And they decided it was very likely that this product was causing the intussusception in these children. And so they pulled the product. That's exactly how it's supposed to work, because we don't want to kill kids, right? We don't want to kill anyone with a product that's supposed to, provide benefits from a health standpoint. So yeah, it seems to me very clear that this is being treated very differently from how we've been treating products that are put into human beings, especially children. Well, yeah, that's a whole other thing. The childhood vaccination schedule is crazy. But yeah, it's cost a lot of lives. And that's another thing that really bothers me about this, because nobody can deny that now. Like, I'm sure that people who've been injured. I'm sure that people who have family members who know, they don't think, they know that the product was responsible for the premature death of their loved one. It's affected every single person, and that's not surprising because, as we all know, billions of shots were rolled out. So
we look at the next slide, Jessica.
Yes, indeed. So this is, again, only showing the reports filed to VAERS for the domestic data for 2021 versus the previous 10 years. You can go back 30 and it's the same trajectory. It's a flat line, no matter how you look at it. So this is the size of the files, because when you download VAERS, you can, if you're a pattern recognizer and an observer of data and numbers, you notice when numbers are escalating every week if you're downloading them. So you can see the rapidity for which the file sizes increase, which means that there's more data therein. So for 30 years, and here I'm showing 10, this is all vaccines combined. The file size and the number of VAERS IDs, these are people now who filed reports on the right, it doesn't change. If you zoom this out, it looks like it goes up slightly. And that makes sense because we have an increase in products going into the market. It's proportional, though. That's the key. So enter 2021, and this new product comes onto the market in full force. We have this insane increase in file size, first of all, which indicates, a lot more reports. And on the right, we see these are the increase in the number of people who are filing reports. So my question is, what explains this if there isn't an increased signal from these products, i.e., if these products aren't causing this, signal in everything you can think of? And that's the next thing I'd like to say something about. What does? A lot of people will say, well, it's just because we put more shots into people. But I've actually done the napkin math. I've written an article about this, and I've proven that this is absolutely not the case. If you simply compare the number of COVID shots to the number of flu shots, only flu, you will see that there are more flu shots, or sorry, there are more COVID shots, about 2.3 times more if you take a certain time frame. I think I did like 465 days or something. And you'll see that there's no proportionality in terms of the number of reported adverse events, or even more importantly, and this is my next point, the range. There's something different, about these products that's causing systematic damage in human beings. And again, I want to reiterate this. I saw this from the beginning, even though the data set was incomplete in the early stages. I saw this. I pulled out clusters of cardiovascular, neurological, pathological, immunological, everything you can think of, rare conditions, rare cancers was manifesting. It's like, how is this possible? This has never happened with any product that we've seen on the market. And so, yeah, that's something that remains unexplained.
Certainly a temporal correlation.
Yeah. So this is what I just explained. I compared the number of VAERS reports for influenza vaccine products only per million doses of influenza. And I got these denominators from CDC. I always take my data directly from their databases, so they can't come back and say, blah, 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 blah. And I compared it to the number of VAERS reports associated with only COVID products. Ooh, I wrote vaccines, that's bad. Per million doses of COVID product. And you can see it's very clear. I mean, all you have to do is take 1 year. I decided to go back 10 because I have the data. But again, I don't even have to make a claim here. All I have to do, in my opinion, is say, explain this. What's causing this fold difference between the number of adverse events per million doses of these two separate products? So yeah, it's not because of the number of shots. That's the point.
Oh, so this graphic is per million doses, Jessica, is it?
Yes.
Yeah. Looks pretty clear.
Yeah. Yeah. And this is what I've already said. I mean, and by the way, this is as of April 21st, although, you know what? I think that's updated to, anyway, it's going up every week. This paints a picture of the spread. So I use CDC age grouping here so that I can normalize the data per age group. So I also take the denominators for each age group here on the right from the CDC. And the disturbing thing about the plot on the right that I'd like to point out is the 0 to 4 category. This red bar on the far left grows really fast every week. And I've been watching this for how many years? This bar is growing faster than any of these other age groups has grown. Now, having said that, I really want to point something out. It's very important when you're looking at this data to look at what you're looking at. So most of the reports, and I really do mean most, I mean the top 10, I think that's the latest that I've looked at, reported adverse events, and I put that in air quotes, for the age group 0 to 4, and this is for Pfizer and Moderna products alike, is it's product error, okay? And that can range from, oops, we put it into someone too young, to, oops, I forgot to dilute it, oops, I diluted it too much, oops, I gave them an expired product, like a lot of oopsies. So if you think about it, those aren't adverse events. And the problem with that is that this great accumulation of oopsies that are being reported in this age group are kind of replacing what could be a MEDRA-coded side effect. So if the person who injected the product recognizes right away that they injected someone with an expired product. Something like 90% of these reports are filed immediately, like day zero. You can tell that from VAERS as well. So they're like, whoops, oh dear, and they file a VAERS report immediately, and it gets into the system. But here's the thing: unless you suffer anaphylaxis, you're not going to really see an adverse event manifest immediately, right? This is my thinking. So if that baby does suffer an adverse event a few days later, and the parent takes their baby into the doctor, a couple of things could happen. Maybe an adverse event is filed into VAERS, but I can guarantee you, from the people I know who know a lot more than this about than I do, that is never going to be updated unless they get a brand new filing, a brand new VAERS ID, and this is the part that gets muddy. But I have it on good faith that if you try to update a VAERS report with, say, I'm going to go all the way to the end, say a baby dies, because this is happening. It's very unlikely that you're ever going to see that manifest in VAERS. What you'll see for baby X is that they were given a product that was expired, for example. So there's 2 points here that I'm trying to make. There is this really fast increase in rate of reporting, but they're kind of not the reports that we need to be caring about here. What we really need to be tracking, because this is what this is for, are increases in myocarditis, increases in severe fevers. I've looked at these reports. I've read so there's a variable in VAERS called the symptom text variable. And this is where like the doctor or the reporter like writes down the notes, and it can be one line or it can be one page. And you get a lot of information in this symptom text report. So I read these. I especially read them for the reports that involve babies or mothers who are breastfeeding or have lost babies, because these are just like the unacceptables to me.
You just clarify the difference between the graph on the right and the left there, Jessica, please.
Sure. The one on the left is like absolute counts. So per age.
Yep. Numbers. Yep.
Each bar represents the number of reports without the underreporting factor. I really have to make that clear. So you have to multiply this by whatever you think.
These, what we want is the actual VAERS numbers. That's what you're giving us.
Yeah. These are people. Yeah. This is a very...
Yeah, they're numbers of people. Yeah.
That's right.
And on the right?
The right is the normalized data of this data on the left. So this is normalized per 100,000 doses. So
okay, right.
328 out of 100,000 doses in the 0 to 4 age group. So that's not a small number. So, and again, not considering the underreporting factor. Sorry, I should have explained that at the start, but
no, it's okay. So we see that there's more vaccines being given in the older age groups than there are in the younger age groups.
Yeah. So that's the importance of normalizing, because if you looked at only the data on the left, and you would say, oh my goodness, look, the 50 to 64s are suffering the most.
Yeah.
If you normalize that to the number of shots, you'll see that it's about the same for everyone over like 25.
Got it.
By the way, this is a typo on the top. I just forgot to change the date. This is actually data from September 22nd, 2023, not April 21st. I just
September. Okay, so that's up to date. Yeah.
So it's just that I forgot to change the date. So yeah, we're looking at and this needs to be contextualized to, the profile of a single. You can just pick the flu vaccine. It needs to be like contextualized to that. This is atypical. Everything COVID related, absolute count wise or normalized, is okay. Just to throw in, we're going to run out of time in 10 minutes, just to put that marker on there. but yeah, it's very important to realize that it's not like, oh, okay, we're just looking at what happens, in the context of any product that we give at this increasing number. No, there's something very different and atypical about these products.
Yeah. It's
Yeah.
normalizing to much higher numbers.
Yeah. Mm-hmm. So, yep, that's and of course, yeah, I think it's in the best interest of everyone to really look hard at what's going on in the kids, because as you know very well, I mean, kids did fine with COVID. They didn't need some kind of intervention like this. They certainly didn't need one that was proving to be unsafe in adults. So again, it's atrocious that they didn't need it in the first place, and that there are 75,000 odd reports in VAERS ranging from high fevers to death. It's about a 50-50 split between male and female children. This is number of people, by the way, number of children. So it's so
75,166 children have made reports, or reports have been made on behalf of those children.
That's right, successfully. So if you want to consider an underreporting factor of 31 times, you can just multiply that number by 31, and you'll probably get a better idea of how many kids in the 0 to 18 age group are actually having side effects from these products. So yeah, it's a lot.
And they're absolute numbers there again, aren't they? Yeah.
That's right.
Yeah.
And these aren't childhood products, by the way. Like, if you compare this to the rates of reporting for actual childhood vaccines, it's like off the scale. And that brings us here to, I mean, I said this at my last parliamentary presentation, not a single child should die at the hands of a product that's supposed to provide protection. Not one. And I really mean that. I'm not trying to be dramatic. It's appalling that this is the number of reports of child deaths. This isn't the number. This is just what we can see with the leaves rustling in the wind of one pharmacovigilance database. So again, I want to reiterate this for all the people who are, slagging VAERS. It's a functioning pharmacovigilance database that's owned by the US government. You can go to prison if you file a false report and they catch you. It's a serious thing. And it's a method that's always worked for us in the past. And again, I'll just throw this in because I've heard that people are saying that VAERS is being over-reported now because of all the media attention. And that's just a funny joke to me. VAERS in the context of hospital settings, i.e. filing a report to VAERS, was almost, the reporting was insignificant, because I always try and get into the mind of the people going through the scenario. So imagine you're my age, you're 48, and you get the shot, and you all of a sudden have crazy chest pain out of nowhere, and you feel like you're tachycardic. You go to the doctor and you're like, oh, and by the way, this was 24 hours from getting a second shot. You go to your doctor and you walk in and you say, I think this is because of the shot I got yesterday. And the doctor says, absolutely not. The shots are safe. The CDC told us these are safe. This is not that. This is something in your history. This is stress. This is you being anxious. And a lot of time, and I'm saying this for a reason, and you probably know this. I've heard this so many times from medical doctors and nurse practitioners. There's a denial, and it's almost a religious denial, that there's a possibility that there's a causal link in even any case between these products and the adverse events that we're seeing reported at exceedingly high numbers and rates. So it's been, just from a logistics point of view, it's been very hard to file a VAERS report. In Canada, doctors were having their medical licenses taken away for filing reports. 5 reports were filed by Charles Hoff in the very, very beginning, 5 that he suspected were related to the products. 5 were rejected. So the concept that VAERS reports are over-reported is a joke. And here we see that 222 reports were successfully filed for children who died in the context of these products. I'm not saying it caused it, but it's possible that it did. And this is the thing that gets me. You have to investigate this from a scientific point of view, and saying that it's impossible that any of these reports are at the hands of these products is not scientific. So I really need to hear a justification of this from the owners of the data, which is CDC and FDA and HHS. It's like, it's not science what you're doing, it's religion. You can't just say
it's rejected before it's been considered.
Yes. Yeah. So this is kind of what I was talking about before. I pulled this out of personal interest. So product administered to patient of inappropriate age struck a note with me a while back. I wrote an article on this. It was around the time when I think it was the 5 to 11-year-old crew was about to be verb packed onto the EUA. And I went into VAERS and I checked out how many 5 to 11-year-olds had filed reports. Now, again, I want to reiterate, this isn't the number of children who suffered side effects. This is the number that successfully filed. And there were thousands. 5 to 11-year-olds prior to a certain date before EUA authorization were not supposed to be injected. They were just not. Definitely not in the thousands, because the clinical trials only had a few hundred, if there ever were any. So something was wrong here. So I looked at this particular MEDRA code. This is the name of the adverse event that's reported, called product administered to patient of inappropriate age. And indeed, it was just rank with children being injected when they weren't supposed to be, like kind of legally. You weren't allowed to inject people before it was authorized. So
is this just over-enthusiastic injectors, or what the heck?
Oh gosh, I don't know, dude. I think it's more the parents. I think it's the parents freaking out and saying, no, it's okay. He's going to be 6 next month, or you know what I mean. I think it's more the parents. So I pulled this out of VAERS, this MEDRA code, and there are different entities that can give the injections. You can get this in the military. You can get this privately. You can get it from a pharmacist, which is what I have here. And I picked pharmacist because I think of them as being kind of authorities, and they know their job, and they're trained, and they know how to give an intramuscular injection properly. You know, they've been instructed on how to aspirate, although you're not supposed to do that in the context of vaccines, I hear. So all of these things. So I found it absolutely...
We won't debate that one now, but yes.
Yeah. I found it absolutely appalling that there were 3,492 reports filed of pharmacists doing this. I find that absolutely appalling. To top it off...
It's incredible. You give the right dose of the right drug to the right patient by the right route at the right time.
Exactly.
5 things to get right. And yet they were given to the wrong patient. It's just incredible.
And look who they were given to. Look at the graph. This is all the reports. I didn't siphon by age. I didn't filter by age. This is a graph that shows all the reports, the people by age, and they're all young people. So it's like, what is going on here? So it needs explanation. Yeah, the disturbing thing about this is that not only were these children injected at the wrong age, at too young of an age, by pharmacists who are supposed to be trained professionals, some of them were actually sent to the emergency room it doesn't seem like a lot. Okay, 4 children were sent to the emergency room, but I'm going to reiterate what I said before. There shouldn't be one, because that child, let's just put it this way, if it was your child and let's say you didn't know that they weren't supposed to be being injected. Let's say your child is 7 and they hadn't emergency use authorized these things for that age group at that time, and the pharmacist did it anyway. First of all, it's my opinion that the pharmacist should know what age group they're supposed to be allowed to inject, because some of the vials have to be diluted and some of them don't, and this is dependent on the age group. They have different colored caps, although some of the colors are the same for different age groups, which makes it really confusing. But this is all very important stuff. And having said that, a lot of reports were filed for having not diluted the product that was meant to be diluted, which effectively means that the child, and in many cases I read babies, were given
overdoses.
And we don't know what's going to happen. That's criminal, if you ask me. That's absolutely, it's beyond unforgivable, because if something happens to that child, based on what we have so far, where we're not even allowed to assume that it could be that these products cause harm, you'll never be able to prove it, type thing. So you won't get compensated. You won't get your baby's health back if it gets damaged. Perish the thought. But these are all very important things to think about. And it's also very important to imagine the shoe on the other foot. This is one of the reasons I'm doing this. I spend so much time doing this. It's because I can really imagine how I would feel if that was my child. So yeah, it's pertinent, even though it's a small number. And I'm tired of hearing that if it's not statistically significant, or if there isn't a large enough people suffering, then it doesn't matter. It's ridiculous to say that. Every person suffering matters, especially if it's at the hands of a medical product. Mm-hmm. Yeah. So this is the infamous myocarditis plot. So this is another interesting phenomena that relates to causality. So if nothing was different between getting one dose and getting a follow-up dose, we wouldn't see this kind of plot. So what this shows is the age again on the x-axis and the number of people reporting myocarditis according to dose. So it's kind of hard to see the colors here, but you can kind of pull out the dose 3 is blue. It's the low number of bars here that's kind of obscured by the green. And then you can see dose 1 in pink. And then you can see dose 2 in green, very clear. So the first thing you'll notice, besides this surge of reporting following dose 2, is that it's occurring in young people. And this is primarily young boys. You can't see this in this plot, but I've looked at this. And it's primarily 15-year-olds. That bar there that peaks is for 15-year-olds. So what's going on there? Why are like 4 times as many reports being filed in the context of these shots in 15-year-old boys for myocarditis? What's the 2-punch mechanism here? What's going on here? Just to fill people in as well, this Bradford Hill criteria, this is a way to assess causality using 10 criteria established by Sir Austin Bradford Hill. Way back then. So you can use this and apply it to epidemiological data or pharmacovigilance data, in my opinion, because this is what they've always done. This is how they assess. They make a causality assessment. So these 10 criteria don't all have to be satisfied in order to arrive at this conclusion of very likely that this product is causing this side effect. You only have to satisfy 5 or 6, according to the WHO, I believe it is. And so one of these is, well, there are many, but one of them is a temporality. So, of course, you have to have one thing come before the other in order to establish a cause-effect relationship. And the shorter the time frame between those two events, the more likely that the thing caused the thing. So, to give an example of this, anaphylaxis is a perfect example. So, anaphylaxis is an acute reaction to a stimulus, or like sometimes people have an anaphylactic reaction to being injected with a product that contains PEG because they have an allergy to PEG. So you'll see that.
What's PEG?
Oh, sorry, polyethylene glycol. And this is one of the component fats in the lipid nanoparticle that the Moderna and the Pfizer manufacturers use to construct their lipid nanoparticles to encase the modified mRNA. So, yeah, so those reactions happen quickly. So nobody would ever doubt that if you gave someone an injection and they had an anaphylactic reaction within 10 minutes, that the reason they had that reaction was because of what they were injected with, something in there. So I'm just going through one of the criteria of this Bradford Hill. So it's astonishing to me that this hasn't been done, and that this kind of figure here hasn't been explained as well. In addition to the sheer number of reports, the range of the systemic nature of the reports, which is much bigger in range than has ever been reported for a product before, things like this. And by the way, this is pretty unique to myocarditis. I've looked at this dose relationship between, or for many adverse events, I've looked at, I don't know, maybe not 100, but maybe not shy, and I haven't seen this. So this is something special to myocarditis. It's very interesting, and I welcome anyone to start a conversation on why we're seeing this this type of behavior. And it's very alarming also when you look at the fact that myocarditis is one of these adverse events that has actually been admitted to be a problem by the CDC. This has been acknowledged. Like this isn't just me saying that I found this in VAERS. Everybody knows what myocarditis is. Nobody knew that 3 years ago. The other thing they're selling in the context of this happening magically starting in 2021, not 2020, is that it's mild and transient. And I want to tell you, from every cardiologist I've spoken to, this is myocarditis, which is inflammation of the myocardium of the heart, the middle muscly layer of the heart that's basically, helps it beat, is not transient. It's, if you get fibrous material growing in place of those cells that are responsible for this muscly, plasticity. I'm not sure that's the right word. The
contractility.
Yes, beautiful. Thank you. If you have a replacement of those two things, and scar tissue, we all know what scar tissue is like, and I'm not saying it's
non-contractile.
Yeah. Exactly. It's the difference between a yarn thread and a rubber band. It's like if you try and pull on a thread of yarn, it won't give. It's that's really a good analogy. It's
intractable, yeah.
Yeah, and so depending on how much damage you sustain and how much inflammation you maintain, it's a very dangerous situation. And I've heard this from Peter McCullough many times. A surge of adrenaline, which happens when we sleep, about 3 a.m., and it can happen when you're exercising. If you have sustained damage in this form to your heart, you might feel fine, but all of a sudden you get a surge of adrenaline, and apparently that can just be the end. You'll sustain cardiac arrest. And I mean, I'm not a cardiologist, but apparently this is what the cardiologists have been seeing. This is
if you have myocardial damage, anything that causes an acute embarrassment or an acute change in the myocardium is going to increase myocardial excitability. So hypoxia, change in acid-base balance, surge of adrenaline, all of those things would increase myocardial excitability, which I think is the problem.
Yeah, it is a huge problem. And again, this is happening, according to the reports in VAERS, primarily in children, young boys. So there might be a connection to androgens too. I don't know. I haven't looked into that, but there's definitely something going on. And if there ain't a cause-effect relationship here, someone has to explain this to me.
Yeah, it's a surprising correlation, if not.
Yeah, that's a nice way to put it. What are we looking at here? Okay, anaphylaxis and sepsis. So this is nice because I just spoke about anaphylaxis. Now, the subtext here mentions something called LPS, contamination, no less. So LPS refers to lipopolysaccharide, which is a component part of E. coli bacteria. So just in a nutshell, there are two ways that have been used recently to produce the modified mRNA. You can use it or make it using PCR, which is what they did in the products that they used in the clinical trials for Pfizer, for example. And you can use a plasmid and an E. coli system to make a lot of DNA. And when your goal is to upscale, which is when you want to change from making a little bit of product for, say, 20,000 trial participants to billions of people, you need a cheap way and a fast way to make a whole lot of product. So this system of incorporating DNA plasmids, which is a circular DNA that encodes, it has a little spike gene inside the circle, is a way to make a lot of that spike gene, okay, in a nutshell. So the E. coli double every 20 minutes. You just give them a lot of food and warmth, and they're like, hee, and they carry on the replication of the DNA. So, and then in the end, after you've done this, you take out your DNA, you use an in vitro transcription method to produce mRNA, or in this case, modified mRNA. And then the idea is to clean away that DNA and the lipopolysaccharide, which comes as part and parcel with the E. coli when you use this system. It's very, very important to clean out that DNA, to clean out that endotoxin, because if you don't, when you inject that into someone, you can cause a whole lot of problems, which is what I'm talking about in about 30 minutes from now. So back to lipopolysaccharide. If you inject this endotoxin into someone at some quantity, and I don't think it has to be a lot, I'm not an expert on this, you can induce anaphylaxis, you can induce sepsis, you can induce toxic shock syndrome. All of these things are bad and they can kill you if you don't get medical attention, if you don't get an EpiPen, if you don't get attended to. Even if you do, sepsis can still kill you. So these are the reports of anaphylaxis and sepsis in VAERS. And I've put a little note on the left here that if you do incorporate this underreporting factor of 31, it looks more like that, just to put things into perspective. This is, pardon me, normalized per 100,000 doses. And the N refers...
This is the actual real VAERS data though, Jessica, is it?
Yes, this is VAERS. This is absolute count to the N, but the bars represent the normalized data. So this is the number...
Per 100,000.
Doses, yes. So although the number, the rates don't look big, my my point in looking at this was to see first, just to get a picture of how many anaphylaxis reports were being reported per age group, because for the longest time, me and a bunch of other people were thinking, well, this is an allergy to PEG, because this polyethylene glycol, like I said, is one of the component parts in the lipid nanoparticles. So if you have a predisposition to having an allergy to this, perhaps from a previous vaccination, then you can definitely sustain this anaphylaxis shock if you get reintroduced to this. But it's very possible that we're looking at lipopolysaccharide contamination from what I just described being the cause of the anaphylaxis. So this is cutting edge right now because of what's been discovered recently pertaining to what I just said by many labs. This contamination issue is a real thing right now. It's been reproduced, and by reproduced, I mean that vials have been sequenced, and that means that we've discovered, instead of just finding this modified mRNA, which is supposed to be the only real thing that we're finding in terms of nucleotides, we're finding DNA, and that's absolutely not supposed to be there. No way. There are thresholds that we as a medical community, health authorities have to stay under in order for products to be passed on to people. You cannot exceed a certain threshold of DNA contamination, for example. It happens, but you can't have too much. You can't exceed certain levels of endotoxin. That's why we do these measurements. However, ... So this is all under a magnifying glass right now. It's very important because it's going to pertain to a lot of people if what we're finding turns out to be a prolific problem. Let's put it that way.
Is there any literature that demonstrates conclusively that lipopolysaccharide has been found in the products? Or is this something that's kind of would make sense consistent with the anaphylaxis data?
Consistent with the anaphylaxis data and the contamination, but I don't think so. I mean, I shouldn't say it that way. What I should say is I'm not aware of any. Maybe there is, but I don't know. There will be.
so we're pretty sure about there's documentation, I think, for the DNA contamotation.
That's on a preprint server. Kevin McKernan has published this.
Is it? Right. And given that there was lipopolysaccharide before it was purified, it's possible that the lipopolysaccharide could be in, and that could be a hypothesis to explain.
That's right.
The increased incidence of anaphylaxis.
And one more piece of evidence, if you want to call it that, is that the only document that I've seen that discloses information about endotoxin measurements from Spikevax has redacted results. And I find that highly, highly strange because this isn't a proprietary thing. This is a test result. This is the amount of endotoxin that was discovered in the shots as part of a like a document that reveals what they found when they were challenged by the FDA, for example. So it's like that one really puzzles me. I can't figure out why. It'd be
very strange they don't want to share the data with as wide a scientific community as possible, of course.
Yeah. So yeah, it remains to be seen. But the thing about this is that the concern is there, and it's being raised by independent scientists who are, these people aren't, fly-by-nights. These are very serious people, like 30, 40-year careers in genomics, for example. So it's like, if there are people that you want to see as an authority, these are the people, for example. And everything that they're discovering and finding absolutely warrants investigation. You don't have to, believe it right away. Like, just to give you an example, one of the independent scientists who's an oncologist who verified this DNA contamination actually set out to prove Kevin wrong. And he was gobsmacked when he found out that, oh, geez, he was right. And he found a lot of contamination. So reproducibility is very important, better than peer review.
Well, we'll have both if we can.
Yes. So this
is the last slide, Jessica.
Perfect timing. So actually, I'm going to have to go in 6 minutes. So there was a publication that came out recently that showed evidence of transfer of mRNA in breast milk. And so this was suspected by many people for quite a while. So I decided to look into VAERS. You can sift through VAERS and filter out women who were exposed to product while they were pregnant. You can also filter them out according to whether they're breastfeeding and whether or not their infant got exposed either by being injected or not being injected and by breast milk, and therefore filed a report. So of the 6,416 breastfeeding mothers that were exposed to COVID products, that means they got injected while they were breastfeeding. There is a small cohort within this group that are babies. So the big cluster here are the moms that were exposed, and the small cluster here that I blew up, the 17 babies, are here. Now,
so these are mums that reported adverse reactions.
That's right.
Yeah, and they're babies that reported adverse reactions.
That's right. So you can imagine that there are a lot more babies that sustained some kind of, like maybe they stopped feeding for a bit, they got fevers, but they weren't reported. So again, I really want to stress this. This 17 number certainly looks low, but I dare say this is just the tip of the iceberg. Now, one thing the last point I want to make is that very common in this 17 number, like the highest preponderance of type of report was a very high fever that lasted a long time. So you know what that means, John. If you are an infant and you are febrile with 104 fever for 4 days, was the case with one, that's really bad for a little brain, is it not?
It is.
So this is very serious, and this can have long-lasting repercussions for the rest of this being's life. So even though this is written down as pyrexia, which is a fever, when you go to the symptom text that I was speaking about before, and you actually read what this infant went through, you'll find more often than not that this isn't just a fever like that babies get, This was a really high fever for a long period of time. And in a lot of other cases, it was co-reported with cessation of eating, diarrhea, other conditions that basically can kill a baby. I mean, it's serious. Yeah. This is what we would call a serious adverse event. So leaves rustling in the wind, again, this is just VAERS data. I use the word just loosely, but it confirms in a way. It doesn't not provide evidence. Let's put it that way. It provides evidence to support what we're starting to see arising in the peer-reviewed literature. So again, we're talking about infants, we're talking about pregnant women, we're talking about a huge percentage of the population involved here. So this really does warrant way more than an investigation. I mean, the very first thing, in my opinion, that needs to happen like yesterday is that the shots need to stop. I mean, then we need to figure out how to help people, because there are millions and millions and millions of injured people right now. And as far as I can ascertain, because it's not being acknowledged that it's possible, they're not getting any help at all. And that's putting it.
I can't say I'm impressed with the pharmacovigilance so far, because the first data we looked at was from January 2021 and it's now October 2023. So I can't say I'm impressed.
Yep.
Dr. Jessica Rose, You're a busy lady. I think you're off to report on something else now to someone else. Please do report back when you've given your talk to the Romanian Parliament and talk to their leading scientists and doctors. It would be interesting to see what a nation that could be considered in some ways perhaps potentially more independent has got to think about this.
You're absolutely right. And I sure will.